Welcome to Chapter 28, entitled Pharmaceutical Care in Type 2 Diabetes Mellitus. There are many opportunities for pharmacists to make valuable contributions to the care of patients with diabetes mellitus. The application of a systematic pharmaceutical care process as outlined in this chapter will facilitate identification of a range of drug-related problems which may be preventing the patient from deriving the maximum benefit to be gained from their pharmacotherapy. Pharmacists should appreciate the needs of their patients and establish systems and infrastructure to permit the provision and documentation of effective pharmaceutical care. Next we will discuss disease definitions around diabetes mellitus. Diabetes mellitus is a complex heterogeneous metabolic disorder characterized by chronic hypoglycemia. The clinical presentation and disease progression are related to the disease phenotype and depend on the degree of dysfunction of insulin-producing pancreatic beta cells, and/or the responsiveness of target tissues, such as liver muscle and fat, to the action of insulin. The current classification of diabetes distinguishes four categories. 1. Type 1 diabetes mellitus, abbreviated as T1 German mark, is due to autoimmune destruction of beta cells leading to absolute deficiency in insulin. 2. Type 2 diabetes mellitus, abbreviated as T2DM, the most common form of diabetes mellitus, characterized by insulin resistance and progressive loss of insulin secretion. 3. Gestational diabetes mellitus, abbreviated as GDM, which involves carbohydrate intolerance resulting in hypoglycemia of variable severity, with onset, or first recognition, during pregnancy. 4. Diabetes due to other causes, e.g., mature onset diabetes of the young, abbreviated as MODY, other endocrine diseases, pancreatic diseases, e.g., cystic fibrosis, or iatrogenic causes, e.g., corticosteroid therapy. Current global estimates suggest that approximately 415 million adults have diabetes, and that this will increase to 642 million by 2040. While the proportion of the population with type 2 diabetes mellitus is increasing in most countries, 3/4 of these live in low- and middle-income countries. Next we will focus on diabetes complications. Chronic uncontrolled hypoglycemia causes damage to blood vessels and nerves, which leads to both microvascular and macrovascular long-term complications. Microvascular complications include retinopathy, nephropathy, and neuropathy. Diabetic retinopathy consists of vascular leakage and ischemia in the retina and is the leading cause of new cases of blindness in adults aged 20 to 74 years. Diabetic nephropathy is the most common cause of end-stage renal disease in developed countries and also an independent risk factor for cardiovascular morbidity and mortality. Neuropathy is a highly variable complication initially affecting the peripheral nerves, and is a major cause of morbidity. It has several clinical complications, including foot ulceration, amputations, gangrene, sexual dysfunction, and even cardiac arrhythmia leading to sudden death. Macrovascular complications related to diabetes, including coronary heart disease, stroke, and peripheral vascular disease, account for more than 50% of the mortality in people with type 2 diabetes mellitus. A person with diabetes has a threefold greater risk of a myocardial infarction compared to someone without diabetes. The atheroma and myocardial damage are likely to occur, at least in part, as consequences of hypertension, altered vascular permeability, and ischemia. However, long-term glycemic control remains the best predictor of cardiovascular disease, abbreviated as CVD, risk in people with both type 1 diabetes mellitus and type 2 diabetes mellitus. Other complications include depression, sexual dysfunction, and dementia. Therefore, a multifactorial approach is essential in the treatment of people with diabetes. Since type 2 diabetes mellitus account for the majority of diabetes cases managed in primary care and community pharmacy practice, this chapter will focus primarily on the pharmaceutical care of type 2 diabetes mellitus. We will now look at the goals of therapy of type 2 diabetes mellitus. A strong body of evidence supports the benefit of control of glycemia, blood pressure, and lipids in the prevention of microvascular complications and macrovascular complications in patients with diabetes. Optimal glycemic targets are especially important early in the course of type 2 diabetes mellitus, as this will confer legacy effect in the longer-term protection from complications. There are international guidelines for the management of diabetes mellitus. The current International Diabetes Federation (IDF) guidelines, recommendations valid for type 2 diabetes mellitus, are as follows. Regarding glucose control, the general target for glucose control in type 2 diabetes mellitus should be an HbA1c less than 7%, that is 53 mmol per mole. Lower HbA1c targets are desirable or at least should be considered, as long as hypoglycemia and weight gain can be avoided using appropriate treatments. An HbA1c target between 7.5 and 8%, that is 58 to 64 mmol per mole, may be more appropriate in patients using multiple medications, including glucose-lowering drugs, abbreviated as GLDs, where predicted survival is short. Glucose monitoring is mandatory for patients using insulin. Glucose monitoring is useful during treatment adjustment, acute illness, or as an education tool for self-care. Regarding blood pressure, patients with type 2 diabetes mellitus and hypertension should be treated to a diastolic blood pressure, abbreviated as DBP, target of 80 mm of mercury, and an systolic blood pressure, abbreviated as SBP, target of 130 to 140 mm of mercury. The lower target for younger people or when additional cardiovascular risk factors or microvascular disease are present. Angiotensin-converting enzyme inhibitors, abbreviated as ACEI, or angiotensin II receptor blockers, abbreviated as ARB, are the preferred antihypertensive medication due to their renoprotective effects. Lipids. All people with type 2 diabetes mellitus and without established CVD, who are 40 years old and have LDL cholesterol greater than 100 mg per deciliter, 2.6 mmol/L, should start treatment with a statin. Primary prevention. In people with type 2 diabetes mellitus who have established cardiovascular disease, The LDL cholesterol target is below 70 mg per deciliter, 1.8 mmol/L. Secondary prevention. And now we will discuss the management of type 1 diabetes mellitus. All people with type 1 diabetes mellitus require insulin replacement therapy either with multiple daily injections, abbreviated as MDI, including basal and bolus inulin or insulin delivered by an insulin pump. The preferred insulin regimen for people with type 1 diabetes mellitus is the basal bolus regimen, which involves 4 or 5 injections of insulin per day, 3 or more injections of rapid-acting insulin to cover mealtime needs, with 1 or 2 injections of basal insulin covering insulin requirements between meals. This regimen mimics the normal physiological pattern of insulin release. Insulin pumps continuously deliver a fast or short-acting insulin into the body according to the patient's needs. The pump is pre-programmed to give small background doses of insulin continuously throughout the day and night depending on the patient's needs. Every time a patient eats carbohydrate, they have to activate the pump to give a burst of insulin. The amount of carbohydrate that is eaten for a meal or a snack needs to be fairly accurately estimated in grams or exchanges. It is critical to match insulin dosing with carbohydrate intake to prevent hyper or hypoglycemia. Table 28.1 includes types of insulins. The most common acute complication of type 1 diabetes mellitus is hypoglycemia, which typically occurs when a patient's blood glucose level falls below 4 millimoles per liter, at which point homeostatic physiological counter-regulatory responses occur. Hypoglycemia is one of the most important limiting factors to the achievement of near normoglycemia in the management of type 1 diabetes mellitus and is one of the most feared complications. Factors that contribute to the unpredictability of diabetes control and the likelihood of hypoglycemia include the following. 1. The uncertainty caused by differences in insulin absorption rates. 2. The variable effects of exercise. 3. The variability of food absorption. 4. The variable effectiveness of different foods to raise blood glucose level. 5. The uncertain effects of physical and psychological stress. Most people with type 1 diabetes mellitus are under the care of diabetes care team, including an endocrinologist, diabetes nurse or diabetes educator, and a dietitian. In some places, a pharmacist will be part of this team where they can contribute to optimizing medication therapy. Next we will discuss the management of type 2 diabetes mellitus. Management involves lifestyle management, including weight management, nutrition, and physical activity and pharmacotherapy. Figure 28.1 gives an overview of the management of diabetes mellitus. And now we will focus on lifestyle modification. Following diagnosis of type 2 diabetes mellitus, the initial management usually commences with lifestyle modification, focusing on both carbohydrate and energy restriction and increase in physical activity. Modest persistent weight loss, defined as sustained reduction of 5% of initial body weight, can delay the need for initiation of pharmacotherapy. However, to achieve optimal outcomes in control of glycemia, blood pressure and lipids, a sustained weight loss of 7% is recommended. This can be challenging for many obese individuals with type 2 diabetes mellitus. This degree of weight loss can be attained with lifestyle programs that achieve a 500 to 750 kilocalories per day energy deficit, or provide 1200 to 1500 kilocalories per day for women and 1500 to 1800 kilocalories per day for men, adjusted for the individual's baseline body weight. Physical activity recommendations to assist in weight loss and reduce insulin resistance include undertaking at least 150 minutes per week of moderate-intensity aerobic physical activity, that is 50 to 70% of maximum heart rate, spread over at least 3 days per week, with no more than 2 consecutive days without exercise. Reduction of sedentary activity, undertaking resistance training at least twice a week and include exercise programs. Other lifestyle measures that need to be considered in the treatment plan for patients with type 2 diabetes mellitus are moderate alcohol consumption, 1 drink for women, 2 drinks for men, and reduction in sodium intake, especially in patients with comorbidities such as hypertension. Figure 28.1 summarizing a model of systematic approach to pharmaceutical care delivery in patients with type 2 diabetes mellitus. Figure 28.1 summarizing a model of systematic approach to pharmaceutical care delivery in patients with type 2 diabetes mellitus. Next we will discuss pharmacotherapy of type 2 diabetes mellitus. If a 6 to 12-week trial of lifestyle modification is not successful in controlling glycemia, or if blood glucose levels are very elevated and/or the patient has symptoms at the time of diagnosis, pharmacotherapy is indicated. There are now 9 distinct oral pharmacologic classes and a variety of insulin and non-insulin injectable medications available for the treatment of type 2 diabetes mellitus. Metformin remains the first-line treatment option for most patients. It targets one of the key pathophysiological features of type 2 diabetes mellitus, namely insulin resistance. However, type 2 diabetes mellitus is also characterized by other types of dysfunction in organs such as the liver, which produces too much glucose, the pancreas where A cells increase glucagon secretion and B cells produce less insulin, and the gut with reduction in glucagon like peptide 1, abbreviated as GLP-1, levels and increased intestinal transit time for food, and the kidney with increased glucose reabsorption. In adipose tissue, visceral fat, dysregulation of hormones such as adiponectin and the production of inflammatory cytokines contribute to insulin resistance. The progressive nature of type 2 diabetes mellitus and the need to tackle all areas of dysfunction imply that combination therapy with classes of medication with complementary modes of action is more likely to achieve glycemic control and importantly preserve beta cell function, the ultimate goal of therapy. Current guidelines advise clinicians to select second and third agents from among the available classes, adopting a patient-centered approach, taking account of patient preferences, tolerability, and individualized glycemic targets. Table 28.1 summarizes the current classes of oral and injectable agents, their mode of action, efficacy, HbA1c lowering, risk of hypoglycemia, effect on body weight, and common side effects. However, studies have shown that many patients do not meet targets for glycemic control, blood pressure, and lipids, putting them at higher risk of developing complications. Both physician and patient factors contribute to this. Inappropriate prescribing or therapeutic inertia, i.e., failure by physicians to intensify therapy to meet recommended targets, or patients' failure to adhere as prescribed to their medication regimen due to a range of drug-related problems. Pause the video and carefully scrutinize Table 28.1 summarizing classes of antidiabetic agents and effects before advancing to the next slide. Pause the video and carefully scrutinize Table 28.1 summarizing classes of antidiabetic agents and effects before advancing to the next slide. Pause the video and carefully scrutinize Table 28.1 summarizing classes of antidiabetic agents and effects before advancing to the next slide. We will now look at drug-related problems. Drug-related problems including adverse drug reactions, interactions, contraindications, and non-adherence can undermine the effectiveness of type 2 diabetes mellitus therapy. Since patients with type 2 diabetes mellitus generally use multiple medications, drug-related problems are likely to occur in this population and can negatively influence diabetes control. Research has shown that a substantial proportion of drug-related problems that exist within the healthcare system are related to patients with diabetes. Two recent studies, which applied the PCNE classification for drug-related problems, explored the prevalence of drug-related problems among patients with type 2 diabetes mellitus. 1. In the community setting or, 2. in the hospital setting as contributing to the hospitalization. The former study comprised home visits to 54 diabetes patients by students interned in 79 Swiss community pharmacies. The most common drug-related problems identified were confusion between trade and generic names, risk of non-adherence, gaps in knowledge about potential interactions and purpose of medication, and hoarding of prescription and OTC medications. The investigation of hospitalization resulting from drug-related problems involved a retrospective review of 300 patients from hospitals in both UK and Saudi Arabia. The main problems identified were lack of effectiveness and adverse drug reactions caused predominantly by polypharmacy and non-adherence, with older age, and using insulin, both significant predictors of the occurrence of a drug-related problem. However, in the UK cohort, adverse drug reactions were the most common drug-related problem, whereas in the Saudi Arabian cohort, it was lack of therapeutic effectiveness due to inappropriate drug and dose selection. Next we will discuss self-management. Self-management is a fundamental aspect of diabetes care which recognizes that the achievement of strict glycemic control is highly dependent on the extent to which an individual is able to self-manage their condition. Successful self-management of type 2 diabetes mellitus requires individuals to engage in various cognitive and behavioral processes on a daily basis to maintain blood glucose levels within the normal range, including lifestyle modifications, adherence to medications, self-monitoring of blood glucose, abbreviated as SMBG, and regular visits to their healthcare professionals, abbreviated as HCPs. For many people with type 2 diabetes mellitus, self-management is challenging as they do not possess adequate knowledge, skills, and motivation to initiate and maintain behavioral changes to help them control their illness. Diabetes self-management education provides a framework to enable an individual to develop the necessary knowledge and skills required to self-manage their condition. Topics include elements of optimal nutrition concerning control of glycemia, i.e., carbohydrate intake, blood pressure, salt, lipids, fats, recommended physical activity, identification, and management of hypoglycemia, especially for people on insulin, secretagogues, sick day management, smoking cessation, if applicable, alcohol use, foot care, instruction on medications, and the importance of regular monitoring for complications. In addition to knowledge, people with type 2 diabetes mellitus also need the self-efficacy and motivation to successfully implement effective self-management. The use of motivational interviewing and collaborative goal setting by pharmacists as complementary strategies to facilitate self-management support have been shown to be effective in improving health outcomes in type 2 diabetes mellitus. Motivational interviewing is based on asking open-ended questions to identify ambivalent thoughts and feelings, and explore patient beliefs about perceived difficulties in changing their behavior. The collaborative goal-setting technique involves the pharmacist and patient negotiating several small, achievable, and specific goals to tackle their most pressing problems. Each goal is supported by a strategy designed to help the patient achieve those goals. The achievement of behavior change is optimized through the patient's personal investment in this process. Another valuable tool to assist people with type 2 diabetes mellitus to achieve optimal control is the use of self-monitoring blood glucose, abbreviated as SMBG. At the time of diagnosis, it serves to enhance an individual's understanding how their diet, lifestyle, and medication influence their blood glucose levels. It may also provide a means for people to actively and effectively participate in the control and treatment of their diabetes mellitus, modifying their behavior and pharmacotherapy as needed, in consultation with their healthcare provider. Self-monitoring blood glucose use requires an easy procedure for patients to regularly monitor the performance and accuracy of their glucose meter. Many blood glucose meters have companion software to facilitate downloading of blood glucose results, which may be reviewed in consultation with their pharmacist and other healthcare professional in their care team. The intensity and frequency of self-monitoring blood glucose is tailored to take account of the individual's specific educational or behavioral or clinical needs, to identify or prevent or manage acute hyper and hypoglycemia, and to produce data on glycemic patterns and the impact of changes in therapy. Thus, pharmacists need to work with patients to assist and support them to make and sustain the necessary behavior changes in lifestyle, to undertake self-care and self-monitoring blood glucose and adhere to the medication regimen throughout their patient journey. Next we will discuss pharmaceutical care in type 2 diabetes mellitus. As a complex and multifaceted chronic condition, Type 2 diabetes mellitus offers a good context for provision of pharmaceutical care within all levels of healthcare where pharmacists are involved or plan to expand their current roles. Pharmacists are ideally placed to ensure provision of responsible drug therapy to achieve optimal clinical outcomes and improve health-related quality of life in patients with type 2 diabetes mellitus, i.e., fulfilling core objectives of pharmaceutical care. Provision of effective pharmaceutical care in type 2 diabetes mellitus demands a systematic approach, especially considering the difficult clinical task of optimizing diabetes mellitus therapy. In this regard, pharmacists should be guided by a model that allows them to assist patients achieve the treatment goals set by the IDF. See above IDF recommendations. From the pharmaceutical care perspective, the process of achieving the IDF goals should consider improving glycemic control without adversely causing hypoglycemia and weight gain, and through interventions that have a positive impact on key indicators such as blood pressure and lipid levels. A systematic provision of pharmaceutical care can be ensured through an initial assessment of patients' medical history, physical, and laboratory results status. This is then followed by considering patients' treatment plan, treatment administration, monitoring, and review. More details of this process, including components involved within the types of pharmaceutical care interventions, are provided in Figure 28.1. This process ensures that there is a system in place that addresses ongoing identification of patient issues, providing continued care and optimal outcomes for the patient. It should be emphasized that during provision of pharmaceutical care, multidisciplinary collaboration of pharmacists with other health professionals should be considered, given that the activities involved in pharmaceutical care provide a good platform for collaboration. This multidisciplinary collaboration ensures optimal treatment selection and achievement of best outcomes for the patient, ultimately leading to improved management of type 2 diabetes mellitus. There is substantial body of evidence reporting the value of pharmacy-based pharmacist-delivered pharmaceutical care interventions, leading to patient support and improvement of type 2 diabetes mellitus management. Studies have evaluated pharmaceutical care interventions in type 2 diabetes mellitus by measuring effectiveness in terms of improvements in outcomes such as in control of glycemia, blood pressure, and lipids levels, body mass index, abbreviated as BMI, adherence to treatment, and resolution of drug-related problems. Economic and humanistic and social outcomes, patients' satisfaction, quality of life, knowledge and beliefs, self-care, and lifestyle, have also been evaluated. Next we will discuss summary of types of activities with accompanying evidence. Studies have reported positive effects of pharmaceutical care interventions on the above-mentioned outcomes. Collectively, these studies provide evidence supporting pharmacists' involvement in diabetes mellitus care in various practice settings including community pharmacies, hospitals, outpatient clinics, and primary healthcare centers. It should be noted, however, that evaluated interventions were multifaceted and with variations across studies. It is difficult to pinpoint which particular interventions are associated with greatest benefits for the patient. A summary of the evidence supporting pharmacists' interventions in key clinical and non-clinical outcomes is provided below. Next we will discuss glycemic control. The literature supports the positive impact of pharmaceutical care interventions in improvement of glycemic control. HbA1c level reductions were reported within ranges of -0.18 to -0.98%. It is interesting to note that the positive impact of pharmaceutical care interventions did not significantly differ between settings, i.e., community pharmacy versus other outpatient settings. Furthermore, evidence suggests that most significant positive effects on glycemic control were reported in patients with more poorly controlled glycemia prior to the intervention and in younger population groups. As age of participants increased, the effects of pharmaceutical care interventions decreased. Next, blood pressure and lipid levels. The review of pharmaceutical care interventions in type 2 diabetes mellitus also highlighted significant improvements in blood pressure control, with studies reporting reductions in systolic blood pressure ranging from -5.6 mm of mercury to as much as -20.05 mm of mercury. Diastolic blood pressure was reported to be reduced from -3.90 to -6.2 mm of mercury. Total cholesterol, low-density lipoprotein cholesterol, and BMI were also improved through pharmacy-based interventions. The literature also supports the benefits of pharmaceutical care interventions in improvement in cardiovascular disease major risk factors. Next we will discuss humanistic and social outcomes. Delivery of pharmaceutical care interventions results in improvement in humanistic outcomes such as patients' health-related quality of life. However, demonstration of this improvement is often difficult and dependent on quality of life measures employed as well as the duration of studies. Nevertheless, significant reduction of hyperglycemic and hypoglycemic episodes among patients participating in a 6-month diabetes management and education program was demonstrated. These outcomes can inevitably have positive effects on a patient's quality of life. Positive economic effects were also reported through involvement of pharmacists in a patient's diabetes care. In this regard, it is worth noting that although pharmacists' interventions may result in increased medication costs, they are usually offset by total medical costs of hospital attendances and admissions. Improvement in medication adherence of patients with type 2 diabetes mellitus is supported by evidence. This is an important aspect of diabetes management that can be addressed by pharmacists given that poor medication adherence is a major contributor to patients failing to achieve adequate glycemic control. Furthermore, this issue becomes more pressing to address given that poor medication adherence is widespread among diabetes patients, with studies reporting medication adherence in the range from 38 to 93%. Worth noting that this difference is mainly due to various approaches in the methodology employed by these studies. During provision of diabetes-based pharmacy services, pharmacists must ensure a range of conditions are met that ensure successful delivery of pharmacy services and interventions. These conditions include an appropriate counseling area that ensures patients' privacy, a fully equipped, e.g., with devices that enable accurate measurements of diabetes indicators such as BGL, blood pressure, BMI, healthcare area for dealing with patients with type 2 diabetes mellitus and adherence to relevant ethical and professional practice standards. Next we will discuss documentation of care. Documentation of patient care is an essential component of care ensuring quality, efficiency, continuity of care, and improved patient safety. See also Chapter 8. In relation to pharmacist interventions, documentation of care also supports the decision-making process and facilitates communication with other health professionals. In general, documentation of care should be legible and accurately reflective of pharmaceutical care provided by pharmacists in various stages, i.e., patient assessment, treatment plan, monitoring parameters, and review outcomes. Furthermore, the progressive nature of type 2 diabetes mellitus makes it essential that pharmaceutical care for these patients is supported by ongoing documentation that ensures prioritization of issues and provision of continued patient care. From the perspective of identifying drug-related problems, the initial patient assessment outlined in Figure 28.1 ensures pharmacists have the information needed to proceed with review of patient's drug therapy, i.e., treatment plan, leading to potential identification of drug-related problems. During identification of the drug-related problems and delivery of subsequent intervention, a number of classification systems have been developed to assist pharmacists and other health professionals in documenting drug-related problems during the process of pharmaceutical care provision. The Pharmaceutical Care Network Europe (PCNE) has developed a classification which focuses on the problem cause, including possible causes for potential problems, planned intervention, intervention acceptance, and status of the drug-related problem. Each of these domains is then elaborated in more detail in specific subdomains. The PCNE classification system can be employed during identification and resolution of drug-related problems as a means of facilitating the process of recording and documentation in patients with type 2 diabetes mellitus. Figure 28.1 outlines a step-by-step approach to identifying drug-related problems and subsequent inclusion into a pharmacist's care plan. Table 28.2. Pause the video and carefully scrutinize Table 28.2, which is a summary of Mrs. N's drug-related problems and interventions using the PCNE classification before advancing to the next slide. We will now discuss a case scenario involving Mrs. N. Consider the case of Mrs. N. She is a long-time customer of your local pharmacy. She is 67 years old and has come to the pharmacy today with a new prescription for vildagliptin, following an appointment with her GP. Mrs. N has had type 2 diabetes mellitus for 13 years as well as a range of other chronic conditions. Her current medications include the following: amlodipine 10 mg main, in the morning. Atenolol 50 mg main, to manage an old myocardial infarction. Irbesartan 300 mg in the morning, an ACE inhibitor-induced cough in past. Gliclazide 80 mg dosed at 1.5 twice a day. Metformin 500 mg dosed at 2 twice a day. Furosemide 40 mg in the morning. simvastatin, Zoca, 20 mg at night. The patient only took for one box course. Her current concerns include the following. Mrs. N has been battling with her weight. BMI is equal to 35 kg per meter squared. For some time. She is also unhappy about having to take yet another type of tablet. She believes that she is already taking too many and even skipped some of her evening medications. Mrs. N considers her diabetes to be well under control given that, according to her, her latest HbA1c level, done 12 months ago, was 8.5%. Without doing too much testing at home, she never had a hypoglycemic episode, and doctor told her today that her blood pressure and lipids are good. Upon further questioning, you understand that Mrs. N also does not understand the value of her losing weight and that she is largely inactive and has an irregular diet. Furthermore, she complains about the remembering to take all of these pills and at the right time. Given that she lives alone, Mrs. N has no assistance in managing all her pills, which adds on to her stress related to medication management. There are a number of key activities which pharmacists can undertake with the view of being actively involved in supporting Mrs. N's type 2 diabetes mellitus. These activities may be delivered within the 5 key stages, i.e., initial patient assessment, treatment plan, treatment administration, monitoring, and review, and through use of specific pharmaceutical activities as outlined in Figure 28.1. Stage 1. Initial assessment. Following the initial assessment of Mrs. N, it can be identified that her new prescription for vildagliptin is likely to be an attempt to escalate therapy in response to Mrs. N's HbA1c of 8.5% and that the furosemide is being taken for swollen ankles. However, the GP is unaware that this lady is not taking her evening doses of gliclazide and metformin. It can also be identified that Mrs. N would benefit from education on her type 2 diabetes mellitus, including medications, complication risk factors and diet, and lifestyle. Stage 2 Treatment Plan. When considering Mrs. N's treatment plan, a number of issues can be addressed, including key indicators, blood pressure, lipids, BMI, diabetes mellitus complications, diet, and lifestyle, indicating the need for a medication review and drug-related problem screening. Drug-related problem screening may be assisted using the PCNE classification system, enabling categorization of drug-related problems in addition to documenting. During the medication review, it can be ascertained that medication adherence has contributed to introduction of vildagliptin, making education on medication adherence one of the priority areas to address. Medication adherence should become part of her pharmaceutical care plan, and a model of ongoing documentation of medication adherence is provided in Table 28.3. As part of this plan, it may be beneficial to explore her reluctance to take the evening doses and pursue this before adding an alternative medication. In this regard, both education and medication access will need to be considered in her pharmaceutical care plan. You also note that she has stopped the statin therapy. Although currently Mrs. N suggests that her blood pressure and lipid profile are satisfactory, it would be beneficial to ascertain this through communication with her doctor. Given that furosemide is being taken for swollen ankles, it may be that this is an adverse effect of amlodipine, hence making further investigation of this potential issue a priority drug-related problem to address. If this was the case, then the options would be to recommend or decrease the dose of amlodipine, given that peripheral edema due to amlodipine is dose-dependent, or cease it, provided that her blood pressure is well under control. Upon further screening for drug-related problems, it can be noticed that Mrs. N is not currently taking aspirin, which may be beneficial given her cardiovascular risk, i.e., treatment missing. This would be discussed with the GP and may require considerable consultation with Mrs. N given her reluctance to addition of new medications. Furthermore, it can be ascertained that her treatment plan needs to consider modifications in diet and lifestyle. Exploration of weight loss options with Mrs. N could be very helpful considering local support resources such as dietitian, exercise opportunities, psychologist if food is being used as a comfort and medication. Stage 3. Treatment administration. During this stage, the pharmacist would need to ensure that all medications are being dispensed accurately and in accordance with country legal requirements. The pharmacist would need to ensure that all medication is being administered correctly and counseling is provided. Mrs. N is currently taking 120 mg of glycoside, meaning that she is halving the 80 mg tablet to achieve this. The pharmacist should ensure that this is being done adequately. Stage 4 monitoring. As part of a continued care for Mrs. N, medication adherence, exercise and diet plan to prevent and screen for complications, glycemic control, and key indicators for type 2 diabetes mellitus will need to be monitored. Table 28.3 has an example of activities and strategies that can be undertaken as part of an ongoing glycemic control monitoring. Stage 5 review. The results of the above interventions should be reviewed at this stage. Specifically, if following consultation with the doctor vildagliptin was not added, i.e., due to the plan to address adherence of metformin and glycoside first, then the results of improved medication adherence will need to be reviewed in relation to glycemic control. If not satisfactory, then introduction of vildagliptin could be considered at this stage, requiring referral to her doctor. Likewise, ankle swallowing resolution post-dose reduction or cessation of amlodipine is reviewed, as well as the effects of lifestyle and diet interventions in her overall type 2 diabetes mellitus management. Pause the video and carefully scrutinize Table 28.3 summarizing examples of a documentation system for activities undertaken as part of a continued pharmaceutical care plan model addressing medication adherence and glycemic control before advancing to the next slide. Pause the video and carefully scrutinize Table 28.3 summarizing examples of a documentation system for activities undertaken as part of a continued pharmaceutical care plan model addressing medication adherence and glycemic control before advancing to the next slide. Pause the video and carefully scrutinize Table 28.3 summarizing examples of a documentation system for activities undertaken as part of a continued pharmaceutical care plan model addressing medication adherence and glycemic control before advancing to the next slide. Thank you.